Why does my arm hurt? From little leaguers to golden sneakers. This is a case-based approach. My name is Mary Lloyd Ireland. I'm a professor at the University of Kentucky, orthopedic surgeon. This was presented at the Sports Medicine Essentials course through American College of Sports Medicine, formerly the Team Physician course. This will be our menu. We'll start with the elbow, then go to shoulder, and then go to conclusions. There will be a time code to tell you where each of these will be in the presentation. Now, when we think about the older individuals, we have to think about a cervical disc herniation as causing arm, shoulder pain. Oftentimes this is night pain. It's excruciating. It's more nerve pain. So in the older individual without a specific mechanism of injury that comes in not wanting to move anything, think about a herniated disc. The diagram here shows C5-6 herniation, C6-7 herniation. These are the most common levels of herniation. And then certainly they can have pain from different discs, different radiculopathy in different areas of the cervical spine, but it is important to do a good sensory exam and know where your nerve sensory dermatomes are, do a good sensory and motor exam, get an x-ray, plain x-ray of the cervical spine, as well as consider an MRI scan and refer them appropriately. There are a lot older patients in our population. The burden of musculoskeletal disease in the U.S., this is a publication about the prevalence and societal and economic costs. This was created by our American Academy of Orthopaedic Surgeons in 2011. There'll be updates. There are more and more total shoulder arthroplasties and reverse shoulder arthroplasties being done in our population. We're living longer. We're driving our shoulders harder, having chronic rotator cuff tears. So in this publication, The Burden of Musculoskeletal Diseases, you can see here where the primary shoulder and shoulder revisions are only 3%. So a lot more hips and knees being done, more total knees than anything, but you can see the alarming statistics of revisions. So we're seeing a lot more revisions, and we don't have a whole lot of options in revising a reverse total shoulder. So you'll hear more and more about that in our older population. Replacement surgery. This was quality measures from the Agency for Healthcare Research and Quality. You can look some of these up on the internet. Knees, 600,000, half as many hips, and then only 53,000 shoulders, so 7% of all joints done. Counseling patients and education, there are a lot of .coms. It's important that you provide your patients with excellent referrals to surgeons that do a fair number of shoulder arthroplasties. There are more hits for lawyers.com, unfortunately, than doctors.com. They're total joint companies. Let me start with that one again. Ready? Yeah. It's important to counsel our patients on what total shoulder arthroplasty and reverse arthroplasties are. This can be done with WebMD, with other .coms. It's a lot of surgery to go through for a total joint. Make sure that your referrals to the orthopedic surgeon are ones that do enough of these and treat their patients as they would want their families or friends to be treated. There are a lot of opportunities for lawyers.com as well as doctors.com. Internet search, osteoarthritis, 12.8 million. Knee arthritis, 8.9 million. Hip, 3.3 million. Supplements, 50 million. So the number of total knee replacements done in these internet search, 3.37 million. Total shoulder, 27.4 million. So again, only like 8% shoulder replacements compared to knees, but it's increasing in frequency, and you may make sure the indications are correct and that your patients are ready for replacement surgery before they have it done. In the mid-'80s, we used staples for stabilization for surgery. This was a staple that was developed by a pioneer in arthroscopic surgery. It was a staple to put the labrum back. Unfortunately, staples and the shoulder, metal around the shoulder, doesn't mix very well, so this caused erosion of the humeral head and significant problems, rapid osteoarthritis of the shoulder. So fortunately now we're better with what devices we use around the shoulder. Rarely do we use metal. We have better sutures, better arthroscopic devices, but beware metal about the shoulder and beware new things that we do with the shoulders because there can be some complications. This is a 35-year-old who developed chondrolysis following a pain pump that was used in his shoulder after he had stabilization. You can see the metal anchors, which aren't the problem, but 3 months after he had dissolved articular cartilage, probably because of the pH of the pain pump, and you can see the spurs that were down here inferior on his humeral head. This is courtesy of David Abbasi and John Badalak, Jeremy Stern. Chondrolysis, this was in Ortho Bullets. You can see the devastating problem here where basically this young individual needs a total shoulder replacement. So there are potential complications. It can be bad with any surgery. We don't use the pain pumps anymore, and hopefully we won't see these devastating chondrolytic problems anymore. Who gets glenohumeral osteoarthritis? Weightlifters, people doing performance-enhancing drug, males, more common than females, use of upper extremity devices for weight bearing, such as if they had a below-knee amputation, using crutches, they end up using their shoulders as weight-bearing joints and they wear them out. This is a weightlifter. You can see his loss of rotation range of motion on the left shoulder. His x-rays looked like this. You can see the significant osteophyte in the lower left, which is from his humeral head. And basically, this was early on. We did a CT scan, see a lot of the osteophytes. Previously, many years ago, we went in and tried to scope these patients. Very difficult because they have a stiff joint. Take the spurs off, but it doesn't work. It doesn't really help. Non-operative treatment of glenohumeral osteoarthritis is supportive, non-steroidal anti-inflammatory medicine, glucosamine chondroitin sulfate. Physical therapy doesn't really help. You can attempt to improve neck position, scapular position, which are altered because of the limited motion and pain. What are the surgical treatments? Arthroscopy doesn't really work. You can do a hemiarthroplasty, replacing the proximal humerus, a total shoulder, a reverse where the glenoid is actually low and the ball is high, biologic resurfacing, or a fusion. Just wanted to show you some of the options here. Arthroscopy is the gold standard for detecting chondral injuries in young patients, but if they continue with the weightlifting, there is continued problem and deterioration of their joint. This is from the American Journal of Sports Medicine showing an algorithm for decision-making approach to patient-based and disease-based factors, and that's what we need in these young active individuals. Not a lot of good choices. This is a 70-year-old, as you can see, has significant glenohumeral osteoarthritis, non-dominant shoulder, limited range of motion, deformity of her humeral head, proximal migration of the humerus, candidate for shoulder arthroplasty. The replacement options, if you have a huge rotator cuff tear, a reverse needs to be done. This shows a shoulder joint replacement. Typically, it is the metal ball, the proximal humerus, with a stem. If you replace the glenoid side, this is what that plastic socket looks like. And this is from the AAOS Ortho Info. So this is an x-ray of a total shoulder replacement. So humeral head is replaced and a plastic glenoid. This shows the capitalized hemiarthroplasty, a resurfacing. And then on the right is this reverse. You have to have a functioning deltoid. It's in cases where the cuff is not repairable and they have osteoarthritis. These are being done more and more. Started being done about 15 years ago in Europe, more and more here in our country over the last 5 years. make sure the patient is ready for this. There's not a lot of good bailout after a reverse shoulder replacement failure. So again, the ball part is proximal, so that's why it's called reverse, and the socket is distal, so to speak. The deltoid has to be working, but it's in a massive rotator cuff tear with osteoarthritis as the indication. Which is safer, organized sport or free play? I'll leave that up to you, but I really think organized sports cause more long-term problems than free play. Both bone forearm fractures are easily treatable, concerning when they happen, but it's much harder and longer impact and not being able to get back to full activities after a UCL reconstruction. These individuals oftentimes are invincible, as this young man who on a skateboard broke both bone forearm, and then he went back on his skateboard and broke the other one. Not going to get hurt. You can tell that in his face, but he does. Adults are obsolete children, Dr. Seuss. So in this presentation, from our young athletes to our older athletes, I've tried to show you what things to use to make the correct diagnosis. In our older golden sneaker athletes, you need to make sure they have a realistic expectation of their shoulder arthroplasty and make sure that you've gone through all other options before referring them for arthroplasty surgery. Thank you very much.